Case is Sharada Bai, Mrs. Sharada Bai, 60 years female patient hailing from Vikarabad who was not formally educated and was farmer by occupation. 17. Patient presented with chief complaints of abdominal pain since 15 days, fevers associated with fever since 15 days, history of hematuria since 4 days and breathlessness since 2 days. I would like to date back my history to 3 months back when this abdominal pain had started. Patient had visited a nearby general practitioner who had given her analgesics for this abdominal pain and also advised ultrasound abdomen. The pain had subsided with analgesics and the ultrasound had revealed a cyst in both the kidneys and also in the liver. And she was advised for referral to higher center, but patient did not comply. Then she was asymptomatic for 2.5 months. Then 15 days back, patient again started developing abdomen pain, which was insidious in onset, gradual in progression. It was a diffuse pain, but it was more in the flanks, and it was throbbing in nature. It had no radiation, and it had subsided with analgesics. This abdomen pain was also associated with history of mild distension. There was also history of early satiety. Then it was also associated with history of nausea and vomiting only since the last 4 days prior to admission. It was a non-projectile, non-bilious vomiting. Content was food particles. Coming to the history of fever, it was only present along with the abdomen pain since 15 days. It was a low-grade fever, intermittent, associated with chills and rigors, and it had subsided with the over-the-counter medicines. She started developing hematuria since 4 days prior to admission. It was a painless hematuria, total hematuria, and it was not associated with passage of any clots. There was history of breathlessness since 2 days. It was of NIHA grade 2 to 3, and it was not associated with orthopnea or PND, not associated with chest pain or cough. On further probing, she told there was no history of burning micturition, frothuria or graveluria. There was no history of pedal edema or facial puffiness. There was no history of urgency, urinary incontinence or double voiding. But she had a significant history of nocturia since 3 years, where she told that she used to get up more than 3 times at night for urination. And she also said that she had increased daytime frequency of micturition as well since 2 to 3 years. There was no associated history of loss of appetite or loss of weight. There was no history of native medicine intake. There was no history of any yellowish discoloration of eyes. The course in the hospital, when she had presented to NIMS, she was told to have renal failure due to the cyst, and she needed hemodialysis immediately. So she underwent 3 sessions of hemodialysis along with 1 PRBC transfusion via a non-tunnel left femoral catheter, and she had no complications during the dialysis sessions. Coming to the past history, she was a known case of hypertension since 5 years, which was incidentally detected when she had gone for some other complaint, and she was advised 1 tablet BD to be taken BD. She doesn't remember the name of the tablet, but she was not compliant with her antihypertensive medications. There was no history of renal stone disease in the past. There were no history of any major surgery except for puerperal sterilization that was done 40 years back. There was no history of diabetes, coronary artery disease, CVA, TB, hypothyroidism or any history of seizures in the past. Coming to personal history, she takes a mixed diet. She has a history of toddy drinking since 18 years, almost around 1 liter throughout the day she used to consume toddy. There was no associated history of smoking or tobacco chewing. She had normal bowel and sleep patterns, except for the sleep disturbances that had secondary to nocturia. Coming to the menstrual history, she attained menarche at 14 years and menopause at 40 years of age, and there was no history of any significant postmenopausal bleeding. And reproductive history, she had 3 normal vaginal deliveries, all were at home. There were no ANC visit, and she was not registered. None of this was registered pregnancies. Coming to the family history, she was born out of a non-consanguineous marriage, and she has around 10 siblings, out of whom only 3 are alive currently, and she is 8th born. She has an younger sister who was 9th born of age 45 years who is currently on hemodialysis, and there is no history of any renal disease, or she doesn't know if they had any undergone any hemodialysis. Most of the siblings who had passed away around the age of 50 years, the exact causes of which she is not aware of. Coming to the medication history, she was advised only 1 tablet for hypertension, which she is taking but not fully compliant. Parents, both of them have passed away, but she doesn't remember for what reason, but they were never dialyzed or no history of any known renal disease. She is not aware of the ages also. To To summarize my history, she is a 60 years old female patient who is a known case of hypertension with a significant family history of CKD on maintenance hemodialysis in one of the sibling, who was now admitted, who was 3 months back diagnosed to have both cystic kidney disease 3 months back, now admitted with abdomen pain, fever, hematuria and breathlessness with a significant past history of nocturia and also polyuria. My differential diagnosis at this point would be an acute on chronic CKD. The acute event is dialysis requiring, where she had undergone 3 sessions of hemodialysis with 1 PRBC transfusion with associated complications. I would like to give a differential diagnosis, ma'am, because she had hematuria and there is history acute event is that she has developed abdomen pain and AKI, ma'am, requiring dialysis, and also hematuria is present, ma'am. Due to probably cyst hemorrhage or cyst infection could have precipitated an acute kidney injury on an underlying CKD. Cyst infection or any UTI associated with cyst hemorrhage. From 12th she was admitted, sir. 12th one session, 13th one session and 15th another session was dialysis. She was given 3 sessions of hemodialysis.
How are you sure that this was AKI? Would it not have been ongoing CKD only just progressing to end?
Because all this had occurred in less than 7 days and also it had acute onset, so I thought it could be because previous we don't have any creatinine values to say that it is a natural
and she was
progression.
asymptomatic also.
Asymptomatic except for that abdomen pain that she had 3 months back.
Patient also gives a history of nocturia.
Yes, yes, sir. Yes, sir.
So she has a nocturia.
Nocturia history is also there.
New in onset.
Since 3 years, she told on probing she had
60
told.
years old.
Yes, sir.
At all you think of ADPKD and whatever. And she has a problem with nocturia since 3 years.
3 years.
So what could have, as sir was asking, can it be a CKD also?
It could have been a CKD also, but I suspected an acute event because she has had infections, features suggestive of infection were there and hematuria is also presented. It could either be a natural progression of the disease or it could have been an acute event which temporarily, because she was dialyzed on 15th and I had examined her on 17th.
Why should you differentiate this? CKD progressing to dialysis requiring stage or an acute event has happened?
To know whether she is a rapid progressor or what
Is it
kind.
for that?
Treatment modality also, ma'am. If it is AKI, if we can diagnose the cause, maybe
for the acute factor, which from the patient can be weaned off from dialysis. Isn't it?
Treatment.
Otherwise, you will be sent him on
MHD.
maintenance dialysis, and he will improve half the way.
Yes, ma'am.
And on that nocturia part, what do you mean by nocturia?
Nocturia actually indicates increased volume of urine production should be increased, but as per definition, it
Is it
says
volume or is it difficulty in concentrating?
because of
If you don't drink water, does it increase the production of urine?
because of concentrating defect, the urine production has increased. If it is more than 33% is one
Can we
definition.
expand the term of nocturia? Can you split the term nocturia? You also said polyuria, isn't it? Which is the increased frequency. So both cannot be the same. There are two different terminologies. So nocturia is
Increased
nocturnal polyuria. It is nocturnal polyuria, not increased frequency.
Increase in volume, yes.
It should be the daytime, nighttime is to daytime urine volume ratio should be 2:1.
1/3 if she is passing at night, then it is not.
That is the definition for nocturia. How that becomes a...
If you ask a urologist the definition of nocturia, it will be very clear.
They told more than once if the patient voids at night also, they consider it as nocturia.
Nocturnal frequency.
Yes.
Why that history is important here?
Ma'am, given the scenario in this patient, it looks like she has a cystic kidney disease.
Now, how that history of nocturia helps you in
Categorizing her, mostly CIN patients, chronic interstitial nephritis patients, they generally lose their urine concentrating ability, ma'am. So these patients can present initially for few years with no other symptoms, with
So they
only
present with nocturnal polyuria.
the
So it is a marker of pre-existing significant renal dysfunction, isn't it? Okay.
ANP levels and ADH levels dysregulation is happening, ma'am. So nocturia can be present in case of CIN
What
patients.
happens to ANP and ADH?
ADH levels are generally increasing in ADPKD patients, ma'am.
This is not specific for ADPKD. It
CIN
is for
patients, CIN.
any chronic pre-existing kidney disease.
Concentrating ability is lost, ma'am. So
That produces increased urine or polyuria. Why specifically nocturnal polyuria? Any circadian rhythm for ADH?
ADH production generally should have been more in the morning and less in the night, ma'am. The circadian rhythm will be disturbed in chronic CKD patients where it is.
What happens to ANP?
ANP levels will increase, ma'am. That is the reason they have polyuria. Antinatriuria.
At night, what happens to ANP? Now, what are the other differential diagnoses for that cystic diseases which was diagnosed 3 months back?
Cystic disease, most common is ADPKD, ma'am. Other things she can have because family history of sibling is there. ADTKD is another possibility, ma'am.
Okay.
Or it could have been an acquired cystic kidney disease also, ma'am. But because liver cysts were also there, it is less likely to be an acquired cystic kidney disease.
What do you mean by acquired cystic disease of the kidney?
More than 3 cysts in single
In
kidney.
which scenario you diagnose an acquired cystic kidney disease?
Chronic CKD patients,
Oh.
most of them would have reached ESRD and for a long time, more than 10 years per se, if they develop on maintenance hemodialysis for more than 10 years.
More than 3 years on maintenance dialysis. Now, why should you look for cyst in a maintenance dialysis patient?
The acquired cystic kidney disease has a higher incidence of turning into RCCs, ma'am.
They are pre-malignant.
Pre-malignant, so we should
Is
screen.
ADPKD cyst pre-malignant?
No, ma'am. It is almost equal. The risk of malignancy is almost
But
equal.
what is the
with
difference
others.
from general population RCC in patients with ADPKD?
Here it is more of sarcomatoid, multicentric, and then bilateral. Less metastasis.
No incidence is equal to general
Incidence is-
population.
Oxybutyria were now for the first time.
Yes, sir. This is the first episode she is mentioned.
And it has subsided.
4 days back, sir. Now it is decreasing, sir. Previously it was totally, completely hematuric. Now also it is blood stained, but the color she says it is decreasing now.
So, ADPKD patients who present with loss in how do you manage them?
Management, sir, initially depends on duration, sir. If it is less than 1 week, generally it will subside on its own with conservative management, bed rest, and then if pain is there, analgesics we can give. Antifibrinolytic agents like tranexamic acid can be tried, sir. If it is more than 7 days, and also with respect to age, if it is more than 50 years, then we should have a strong suspicion for malignancy in such patients. If it is causing hemodynamical instability, then we might have to do a renal angio and then plan for an embolization.
What are the
as well.
causes for hematuria in these patients?
Hematuria, it can be a cyst hemorrhage, ma'am. Another cyst infection or any UTI or stone related, it can be, ma'am.
Are they prone for stone disease?
Yes, ma'am.
Why?
They have hypocyturia, uric acid excretions,
Common
and
type
low
of
urine
stones in
pH.
ADPKD?
Common type is calcium oxalate, ma'am, but
Is it?
uric acid stones are more
common
in
is uric
ADPKD.
acid stone. And malignancy.
Malignancy is also another.
Now, why should you differentiate? Only 5 minutes more? We have just started.
So exam is the final.
They have to finish by 5:30.
Female patients with history of multiple pregnancies, estrogen, it is supposed to increase the size of the liver cyst. So female patients and those with history of previous pregnancies are at risk for liver cysts. And also OCP intake with estrogen containing OCPs, if they had taken, that is also significant.
And which patients have larger liver cysts?
Patients with mutation in GANAB mutations can have large liver cysts.
Again, it's females actually
Females.
who have larger cysts.
Severity and number of cysts is more in females when compared to males.
Has any of you seen a patient where the kidney function is normal, even though the kidneys are cystic, polycystic, but the liver is so huge that the patient is symptomatic due to that? It's a rare phenomenon, but I think I have till now seen about 4 patients of that kind. One of them very recently, the whole upper abdomen was filled with the liver and the stomach was compressed, pushed posteriorly, and the patient was losing weight, she could not eat, and the serum creatinine was normal. So sometimes, once in a while, you will see this kind of, it's rare, but you will see a patient where the liver symptoms dominate. And what kind of treatment would you consider for such a patient?
We can do cyst open surgically. We can do fenestration of the cyst or marsupialization process.
Yeah, that is what used to be done at one time. You heard of it?
Sclera.
Name of that operation?
Marsupialization.
Ropsing's also.
Ropsing.
Used to be done for the kidneys, normal was given up. Yeah, you can think of doing something like that, but even that may not work because the cysts will fill up again. So what you need to do, this patient that I am talking about is yet to be done. So the surgeons were thinking of doing a left lobe hepatectomy so that the pressure on the stomach goes away and then
Appetite.
she can be able to eat properly. But this is of course a very rare situation. I just mentioned it because we have seen it.
What do you think, why patient has acute deterioration? Just one cyst infection, does it lead to some sort of a renal failure requiring, he was breathless also, so requiring dialysis support.
Probably she was asymptomatic, sir, but
Any other event also matter, she's also hypertensive, how was the blood pressure?
blood pressure was under control, sir, on examination also, and
At the time of presentation, whether she had an accident hypertension or not.
as per history there were
And
no
as per history,
features.
She had hypertension since last
5 years, but
What is the
poorly
reason for
compliant.
hypertension in this patient?
Hypertension in ADPKD could be because as such blood supply in ADPKD kidney is less, sir, comparatively. So secondarily RAS activation,
Repeat again.
blood flow to the kidneys is generally less.
Not a renal artery
Renal arteries are normal.
Renal arteries are normal.
These polycystin proteins are also expressed on the vascular endothelial cells as well, sir. So they can impart some amount of vasoconstriction. So theoretically, they said that it can, and RAS
What is
activation.
the usual cause of hypertension?
What is the
Cysts
reason
are
for
doing something.
Cyst pressure of cyst on the vasculature is one cause, and renin-mediated RAS
Compression of the
activation.
functioning parenchyma, isn't it?
How does it lead to hypertension? Compression of the vessels and parenchyma.
Ischemia, secondary to this compression, ischemia. To the functioning nephrons and glomeruli can have ischemia,
So that
and
leads to
can
what?
RAS activation, and that can
That is one
cause,
reason. Second, as the GFR deteriorate, they can have salt and water retention and hypertension. Any other reason? Do you want to differentiate cyst infection and then pyelonephritis here?
yes, ma'am. In terms of management, cyst infection specifically needs
From a diagnosis. I asked you a question.
diagnosis.
simply having a cyst infection is having this sort of problem. You want to have any pyelonephritis also one of the diagnoses.
Yes, sir. UTI.
How will you
could be
differentiate
any-
these two?
Generally, the cysts are non-communicating, sir. So culture positivity might indicate pyelonephritis more than cyst
Which
infection.
culture?
Urine culture, ma'am.
Okay, indicate
Pyelonephritis more than cyst infection.
blood culture.
Blood culture could indicate could
can
be
be
because
both.
of both cyst
It can be
infection
both.
or UTI. To specifically confirm the diagnosis or to say more in favor of cyst infection, we need a CT or MRI imaging, or FDG PET is more reliable.
So why only one cyst is infected? It should not lead to the other parenchymal failure, which requires a emergency diagnosis.
Probably associated cyst hemorrhage or
Cyst is also limited to one
One.
diagnosis. Unless it has some blood into the ureter and blocks the ureter bilaterally, then you have acute renal failure which requires dialysis.
obstructive
Otherwise, what madam was saying, acute pyelonephritis.
pyelonephritis.
Polycystic kidney disease are more prone for pyelonephritis compared to the
Yes, sir.
normal kidneys.
Yes, sir.
Why?
Structurally, concentrate.
Is it severity more or frequency is more?
Frequency is more, sir. Severity is similar to that of general population. Frequency is urinary tract infections are more common in IDPKD.
Confirm your statement. Are UTIs are more common in ADPKD people? Why? If it is so, why? I can understand. We can understand like any stricture urethra or BPH. They are more prone to develop some or reflux sarcopathy. They are more prone to develop recurrent UTIs. But why ADPKD should have more UTIs?
It is a ciliopathy, sir. So probably associated lower.
So you are linking E. coli cilia with
No.
kidney cilia.
Any difference in management between these two?
For cyst infection, we should be sure that we give antibiotics that has proper cyst penetration. Lipophilic antibiotics are more preferred in case of cyst
Duration of
infection.
treatment?
Duration of treatment of in 1 to 2 weeks, ma'am. 7 to 14 days of treatment for
For
cyst
cyst
infection.
infection.
Pyelonephritis 1 week for IV antibiotics can be.
For cyst infection, you require prolonged treatment, isn't it? 4 to 6 weeks of antibiotics.
Even cyst drainage may be required because when there is cyst infection, it may be just 1 or 2 cysts which are infected in one kidney, may not be bilaterally. And if you're late, there will be pus in those cysts.
Renal
There
abscess.
will be localized tenderness over the area which is infected. Sometimes you can detect that also. And you may need to
Puncture.
drain that cyst for relief, because if there is pus collected, you have to drain it. So it's very different from an acute pyelonephritis. And it's rare as compared to acute pyelonephritis. Cyst infections are rare.
How will you assess the prognosis of this patient? First presentation on family screening detected her some cyst in the kidney.
Prognosis, we can use pro-PKD score, ma'am, clinical.
What are the
components,
parameters? And
Male gender has 1 point, ma'am. History of first urological event or hypertension before the age of 35 years give 2 points each, ma'am. And one genetic mutation should have been done. If it is a PKD truncating mutation, it gives 4 points. If it is non-truncating, it is 2 points. PKD2 has 0 points. And then we risk stratify it as 0 to 3, 3 to 6, and more than 16.
what are the measures to be taken to prevent progression to CKD?
Ma'am, it is found that if we can control the cyst total kidney volume, it has a correlation with the GFR.
Which
For
study found that total kidney volume is the most important prognostic
CRISP
factor?
study. As
Okay.
So our aim should be, one is to manage the hypertension.
What are the things you can do?
lifestyle modification, hypertension management, and then we should do an MRI or CT and identify the class of cyst which Mayo classification she fits into, and then we should determine if she is a rapidly progressing patient. Based on if she belongs to C, D or E, then she is 60 years, ma'am. Generally, if she had been less than 55 years, then we could have considered tolvaptan to reduce the progression of cystic growth.
Anything else can be done before tolvaptan?
Salt
What is
restriction.
physiological suppression of your V2 receptor?
Physiological way is
How
by
can you suppress V2 receptors?
water, increased water
Hydrotherapy.
intake.
Hydrotherapy, isn't it? You are preventing the secretion of AVP at all, isn't it? So,
As part of hypertension management for ADPKD, as such, salt restriction not indicated. Less than.
what are the landmark trials with Vaptans in ADPKD?
There are 2 trials, ma'am. Tempo 3:4, Tempo 4:4, and Reprisal. 3 trials are there, ma'am. The Tempo 3:4
Now,
trials.
what are the other drugs has been tried in this scenario?
Octreotide analogs like somatostatin, lanreotide, pasireotide has been tried, ma'am.
What was the name of the trial?
DIPAK, Deepak 1 and
Aladdin. Aladdin trial.
Aladdin trial, lip trial.
Then?
Other drugs, metformin is being recently tried, ma'am.
Okay.
That trial is
Then
IMPEDE trial.
other drugs?
Pravostatin in children, it was tried, ma'am. Statins. mTOR inhibitor was tried, but it
What
has
was the name of the trial?
mTOR name.
Serena. Then
It did not show any
pioglitazone.
Pioglitazone. Similar.
What was HALT PKD trial?
HALT PKD trial, there are 2 HALT PKD trials, HALT A and HALT B. They had tried whether intensive aggressive BP management was a standard BP control, and also either a benefit, is there a benefit of both combining AC and ARB together versus only giving AC inhibitor. In HALT A, they have found that intensive BP control
Do you
is
want to screen him for berry aneurysms?
if there is family history or if he is in a high risk occupation, then it is better. Otherwise, routine screening
What are
is
the
not
indications for screening for berry aneurysm?
either history of CVA in this
1.
patient previously, or
2.
if there is any family history of hemorrhages, or if he is belonging to a high risk occupation like any pilots or something, he
What is the
should.
overall chance of having a berry aneurysm?
8% in
Commonest
ADPKD.
site of berry aneurysm?
Posterior circulation stroke.
Commonest site is posterior circulation. It should be interfered. Whenever there is a posterior circulation aneurysm, it should immediately interfere. Commonest site is
Anterior.
communicating between anterior cerebral and communicating junction. That is the most common site. Commonest presentation of these patients?
With aneurysm, subarachnoid hemorrhage.
In a patient with CKD of any etiology, when would you initiate dialysis?
Any etiology, CKD, if there are uremic features, we can initiate dialysis. Like if there is any metabolic acidosis, volume overload feature.
These are for urgent dialysis. But if none of those features are there, is there any trial which has compared early versus late dialysis in CKD?
CKD.
Based on EGFR, 12 to 14 versus 5 to 7.
There was an Australian study that was done which compared patients who had a GFR, EGFR.
What was that trial? Sir is discussing? Ideal trial.
So patients with a EGFR of less than 5 to 7 and more than 10. So they found that there was no advantage of early initiation of dialysis. So if there are urgent indications, that's a different matter. If there are no urgent indications, then there is no advantage, no reduction in mortality from dialysis.
Have you heard of ideal ICU trial? What is that?
AKI, early
versus late
initiation.
Generally we talk of early initiation in AKI,
AKI, yes.
but this is CK. And incidentally, even there is no value, no
Benefit.
proven value of early initiation.
Will you think of starting CAPD for this patient?
CAPD is not a contraindication, ma'am, but
Problems of
complications.
CAPD?
Hernia, already abdomen is
More chance of hernias too?
And then catheter related injuries.
Technical complications,
complications
catheter introduction, injury
and
to
then
the cyst,
dwell
etc.
volume, to achieve adequate dwell volume that we need, a patient might have discomfort when we achieve such a high huge dwell volume in
So
abdomen.
efficiency of PD may not be adequate. Then? Any increased incidence of peritonitis in them? No.
Not
What are the problems of hemodialysis in polycystic kidneys?
anticoagulation during this episodes of cyst hemorrhage can worsen the bleeding.
Okay. More of cyst hemorrhage or bleed. Then? More important than that? Access related problems? Difficult to create vascular, as you said, all these proteins are expressed on the vessel wall also. So access creation may be difficult.
If a uremic patient on dialysis has bleeding, say from the GI tract, so how do you control that? Take care of that?
If it is uremia related, then platelet dysfunction is more common, sir. Platelet aggregation defects are common. If we control the uremia, then bleeding episodes will also.
How do you control uremia?
Hemodialysis.
So one of the things you can do is
Dialysis.
adequate dialysis. What else can you do, supposing that doesn't work?
Prevent bleeding, desmopressin can be used.
How does it act?
Sir, desmopressin is V1 specific, sir, so it can act on the vessel wall and cause vasoconstriction of the vessels.
Another thing, does it increase platelet aggregation?
It has been tried in von Willebrand's disease as a part that it can release that.
Anything else? One is cryoprecipitate. There is an acute large bleed, and that's another thing that in an emergency situation you should use. Desmopressin dialysis you already talked about. Erythropoietin is another thing, but just by raising the hematocrit, also the risk of bleeding stops. And finally there is estrogens, conjugated estrogens. Those can even be used, supposing a uremic has to undergo a surgery and you want to be sure that no bleeding takes place intra-op or post-op. You can use conjugated estrogens. So an easy way to remember all this, just remember C, D and E. C is for cryoprecipitate, D is for dialysis and desmopressin, and E is for EPO and estrogen. Just my way of remembering.
Next case, my second patient is Mr. Biksham, 70 years old male coming from Warangal. He has studied, 70 years old male patient. Studied up to 3rd standard and he is also a farmer by occupation. Informant is self and his son. Reliability is fair. He was admitted at NIMS hospital on 12th and he was examined by me on 17th. Patient initially had presented with complaints of pedal edema and fever for 15 days. History of presenting illness, I would like to date back my history of presenting illness to 2014. That is when patient was 61 years of age. When patient had similar complaints of abdomen pain, pedal edema and fever, and he was diagnosed at that time which were 2 mm and was advised conservative management with medicine. And at that time his physician has also told him that he has some amount of renal dysfunction with a serum creat of 1.6. Between 2014 and this present admission, he was lost to follow-up. 15 days back, patient had developed pedal edema, which was insidious in onset, gradual in progression, and it was up to mid-shin. It was not associated with facial puffiness or abdominal distension. History of fever was also present since 15 days. It was high-grade fever, intermittent, associated with chills and rigors. So with these complaints, 1 week after the symptom onset, he was taken to a private hospital where he was admitted and he was told that his renal functions failure had worsened since his previous values, and also he was given some IV medications there. After a 1 week stay there, since his renal functions continued to worsen and also fever had not subsided, he was referred to higher center and he was admitted here in NIMS on 12th. On admission here, patient had altered sensorium. His attender remembers at that time patient had an BP of 210 and low sugar of up to 30 glucose. For which he was given some IV medicines, after which his BP had controlled and sugars had also come up. His sensorium had improved at that time. Patient during the previous hospital stay, patient had also history of decreased urine output since 5 days there. He has history of abdomen pain and burning micturition. And he had further probing, he told he had passed stones in urine in the period when he was lost to follow between 2014 to 23. So with these complaints, patient was here initiated at NIMS on hemodialysis, where he had received 2 sessions of hemodialysis via left non-tunneled femoral catheter. Post the dialysis, after stabilization, patient was taken up for stenting bilaterally. Further, on probing, patient told he also has history of difficulty in passing urine in form of he has to strain while initial micturition phase, and he also has history of urgency and history of increased frequency, nocturia, and also he has history of poor stream of urine. There is no history of hematuria, no history of passage of any fleshy material in urine. There is no history of nausea or vomiting, no history of loss of appetite or loss of weight. Coming to past history, he is a known case of diabetes and hypertension since 2011, and he is on single oral 1 tablet for diabetes and he is on 1 medication for anti-hypertension, for which both the names the attender or patient doesn't know. There is history of ischemic CVA in the same year 2011. He had a right hemiplegia. There is no history of any coronary artery disease, peripheral arterial disease, or any history of foot ulcers or TB. There is no history of any native medicine intake, or there is no history of any surgeries in the past. Personal history, he takes a mixed diet. There is history of smoking since 30 years with 15 pack years. There is no history of alcohol intake. There is history of constipation present on and off. There is no history of sleep disturbances. That's it. Medication history, he has on oral OHA, single OHA and also 1 antihypertensive. And also he said that he takes 2 other drugs for stroke, probably a antiplatelet and a statin. Family history, he is born out of a non-consanguineous marriage. He is a single son. His mother had died because of CVA and she also had hypertension. He has 3 children. One of them has diabetes. His second child is 40 years old. He is diabetic. And there is no his family history of any renal disease in them. To summarize, he is a 70-year-old male patient with the known case of known with comorbidities of hypertension, diabetic, and past history of CVA 12 years back, with significant past history of renal stone disease 9 years back, and history suggestive of lower urinary tract symptoms since 3 years, with also history of intermittent passage of stones in the last 9 years. Now presented with pedal edema, fever, abdomen pain, and decreased urine output, which had required dialysis 2 sessions along with 1 PRBC transfusion, followed by bilateral DJ stenting. So my diagnosis is here, a syndromic diagnosis is acute and chronic CKD. The acute component being a complicated UTI, probably pyelonephritis. Etiological CKD component, I would suspect most likely a non-diabetic kidney disease in this patient, probably a CAN CKD. The etiology for the chronic kidney disease could be either a renal stone disease or a chronic obstructive nephropathy. Given his age and also lower urinary tract symptoms, I would like to consider BPH as one possibility. The acute component, pyelonephritis, again could have been due to the renal stone disease, BPH, or because of his age, some malignancy causing obstruction also is one possibility. On examination, patient is conscious, oriented. Sir, because given his long history of smoking, any bladder malignancy, but he could have also presented with hematuria, bilateral obstruction. Hematuria, gross hematuria would have been present.
How about your differential diagnosis?
Sir.
You only have to finish the examination.
Yes, sir.
Your positive things are
Mild pallor was
examination?
mild pallor was present, sir.
What are you trying to look at? Based on
Renal angle tenderness, on abdomen examination, I tried to look at. Rectal examination, I had asked, but patient did not consent in
renal
view of
tenderness for what purpose?
pyelonephritis if you are suspecting renal angle tenderness, or and his residual paralysis findings are there in CNS, where there is slightly decreased power on the right side. Fundus examination I had done, there is no evidence of diabetic retinopathy changes.
Peripheral
vasculature, all the pulses were felt in the present, ma'am. Sensory examination of vibration.
Peripheral vessels?
Sorry.
Bruit over the
No
peripheral
bruit.
vessels?
No bruit.
Why all these questions?
Macrovascular complication of diabetes.
CV,
Yes.
he's a heavy smoker also.
Yes. Peripheral arterial disease we should rule out, given his background of stroke and also diabetes and
So he has no evidence of vascular disease.
no history of peripheral
fundus
neuropathy.
retinopathy is also absent. So what is the likely cause of CKD here?
In non-diabetic kidney disease is more
Due to?
CI and CKD stone related
Obstructive
chronic
nephropathy.
obstructive nephropathy.
Obstructive nephropathy due to stone disease.
Stone disease.
Okay.
So why you want to rule out diabetes? You have a long history of diabetes since 2011 to 23 means long years of diabetes.
Yes, sir.
So what made you to think that you like to rule out diabetes? Okay, first instance itself, you thought it was non-diabetic.
Sir, based on the examination and history, there was no history of any pedal edema or in terms of like there is no history suggestive of any previous pedal edema or decreased urine output. The volume overload,
Edema suggests what?
proteinuria.
Does all proteinuria have
No, sir. Generally, more subnephrotic and nephrotic range can have pedal edemas.
nephrotic syndrome patient? Like how many diabetics will present as nephrotic syndrome?
Diabetes is the most common cause of secondary nephrotic syndrome, sir.
How much diabetic
Percentage.
nephropathy patient? Let us say 100 patients with diabetic nephropathy. Among which, how many will have nephrotic as a presentation? How many will have subnephrotic as a presentation? Like this case, you are thinking that lack of
30 to
absence
40% can have nephrotic range proteinuria.
50% don't have.
That might not be the presenting features, sir. Probably later on they might.
What is the acute factor do you think in this patient?
The absence of diabetic retinopathy and other there fundus examination, there was no retinopathy. No history of pedal edema or
Patient was totally
proteinuria.
asymptomatic for
Asymptomatic.
15 years in between.
Yes, ma'am.
Isn't it? So they're unlikely to have significant proteinuria. What is the possible reasons for that acute AKI that has happened superimposed on that CKD?
AK, one could be complicated due to a
Is it acute and
pyelonephritis.
chronic
Yes,
renal disease?
acute and chronic kidney disease. Complicated due to a pyelonephritis.
Acute pyelonephritis,
nephritis could
1,
have-
2, because he presented with fever, striker, chills, etc.
Any papillary necrosis because diabetic.
He had a
could have-
bilateral ureteric obstruction. Bilateral DJ stenting was done as
Yes,
per
ma'am.
history.
Renal stone disease.
Possible reasons for that bilateral obstruction?
One is renal stone disease. First possibility is renal
Bilateral
stone.
staghorn calculus. He was totally asymptomatic with bilateral obstruction. Staghorn calculus. Then papillary necrosis. He had an acute pyelonephritis now, isn't it? Papillary necrosis is also another possibility. Okay.
Cystopathy. If he had had any other peripheral neuropathy or autonomic features, diabetic cystopathy also one of along with the precipitating cause we could have thought of.
And he may have some bladder calculi also,
Yes, ma'am.
producing
Bilateral
obstruction
obstruction.
and lower urinary tract symptoms.
What has happened after the stenting?
His urine output has improved, sir. He was admitted on 12th. One session was done on 12th. Second session was done on 13th, and he was taken up for stenting on 14th, sir. Post the stenting, he has had a good. Initially, before presentation, 5 days he had decreased urine output. Now his urine output has increased, and pedal edema has also decreased, sir.
So, what are the predictors of renal recovery after relief of obstruction? Predictors of renal recovery after obstruction.
Post obstruction is relieved if adequate urine output is.
So, post-obstructive diuresis.
Diuresis.
Post-obstructive diuresis.
Diuresis. Then on imaging, the cortical thickness.
Cortical
should have-
thickness by sonography.
Sonography.
Duration of
Resolution.
obstruction is very important.
Chronic obstruction. Poor prognosis.
If you know the duration.
Yes.
What are the commonest stone in the general population?
Calcium oxalate stones are more
Calcium
common.
oxalate. What is the commonest cause of calcium oxalate?
Idiopathic hypercalciuria, primary hyperparathyroidism, distal renal tubular acidosis can present with renal stones. No, sir. Distal RTA, we generally get calcium phosphate stones because urine is alkaline. More chances of calcium phosphate stones are more common.
This patient had past renal stones.
Yes, sir. He has a significant disease that he has passed stones in the urine.
Is it worthwhile to do a stone analysis?
Yes, sir. Because he is a recurrent stone former and for such a prolonged period, it is better to do a complete metabolic evaluation in this patient.
Fine. Stone analysis.
Stone analysis also, mostly the stone analysis might turn out to be a calcium oxalate stone, sir. But if it turns out to be caused just due to other stones, then the treatment can prevent the further stone formation.
So how do you do stone analysis? What method is used?
FTIC, FTIHC, not full form, spectroscopy.
F stands for Fourier. Fourier transform. Infrared spectroscopy. That is the best method of chemical analysis of stone.
How will you evaluate his metabolic profile?
Basic
stone disease?
evaluation and then metabolic evaluation. Basic evaluation, we should get a serum calcium, phosphorus, PTH, vitamin D, ALP levels tested, ma'am. That will also be as a part of his MBD
And?
profile. And this metabolic profile, we should get a 24-hour urine estimates. We have to do it twice, ma'am. And that should also be done after this acute event, at least minimum of 4 to 6 weeks
Do you
gap.
know what
should
are the
be.
normal value of 24-hour urine calcium, oxalate, uric acid?
Calcium, it should generally be less than 4 mg per kg. For males, it is less than 250 to 300.
Oxalate?
Oxalate less than 45 milligrams.
0.7 mg per kg. When will you say there is hypocitraturia
If it is less than 2 mg per kg, then it is hypocitraturia.
in adults?
Less than 320 milligrams, it
325
is.
How will you prevent a further stone formation in a patient who came to you with a stone disease?
Here again, we should emphasize on hyperhydration. Hydration should be adequate, ma'am.
Okay.
Then supplemental calcium, dietary sodium restriction, and then supplemental calcium should be avoided.
What are the two level 1A evidence?
For recurrence? Sodium restriction.
Sodium restriction and fluid intake.
Fluid intake.
These are the only two methods with a level 1 evidence. All others are plus minus. How will you restrict your diet in a hyperoxaluria?
Oxalate rich foods should be avoided.
What are
ma'am.
those oxalate rich food?
Chocolates, nuts, green leafy vegetables, spinach, tomato, then
Only the seeds
coffee,
in the
tea.
tomato, not in the outer this one. All seeds in the vegetables are rich source of oxalate.
tofu, protein.
Any other drug has been advocated to prevent GI absorption of oxalate?
GI Oxalibacter firmigens
Oxalibacter
can be given.
Prevent GI
Probiotic.
absorption, absorptive hyperoxaluria.
The patient also has severe hypertension.
Yes, sir.
200 blood pressure.
Yes, sir. On presentation,
What is the contribution for renal failure in this patient?
could have been, sir. He had an accelerated hypertension, but it
The
got.
reason for it is because only plain non-diabetic kidney disease you are thinking.
The infection, pyelonephritis, and the systemic inflammation could have added on to this acceleration.
Hypertension for 10 years.
But it was on single antihypertensive. Ma'am, this presentation, that too only after coming here, he was found to have one episode, and during examination also his BP was around 130/18.
But you like, time of admission 200 plus.
Yes, sir, 210 it was present, sir. He as per attendant. Yes.
What could be the reason for it? Whether pyelonephritis can result in hypertension?
A pyelonephritis causing AKA can have accelerated hypertension as a presenting features. Sir.
How does it cause hypertension? Acute glomerulonephritis is not that hypertension, but acute pyelonephritis is a result of hypertension. And patient already had a long-term history of diabetes. And
Yes, sir.
hypertension. He had a
Since
stroke,
12
vascular
years,
disease
sir.
also there. Do you want to rule out a vascular disease in this patient, like renovascular disease?
We
Apart
should.
from that, okay, good. Let us not think about only one way, because this patient is a 70 years old with history of
There
diabetes.
could have been
hypertension,
an
stroke.
additional atherosclerotic renal artery
So how do you,
stenosis.
madam, I'll pertinently ask regarding pulses,
Yes.
bruise. With that intentionally, madam asked that.
Yes.
Did you focus on that?
I had done pulses. I had checked everywhere. Renal angle tenderness, bruise.
But you are already mind to skew towards a non-diabetic kidney disease rather than a diabetes. And what about the poor stream of urine and one more
Lower urinary tract symptoms, it was present since 3 years, sir. Probably given his age, he could have had an associated benign prostatic hypertrophy.
How does it contribute to the renal failure in this patient?
It could have been an additional factor for this chronic obstructive uropathy, that we could have had a significant post-void residual urine, and maybe he could have had some lower grade of secondary reflux also because of
Reflux,
long
or it prompts for more infections?
infections and
So in this patient, is obstruction is responsible or infection is responsible for acute urination or hypertension? What does driven this patient to present in acutely?
Since his prognosis post DJ stenting has improved, urine output has improved, and his clinical status has improved, primary event could have been an obstructive nephropathy.
With what? Is it a stone or a
Stones probably. With DJ stenting he has improved, and for BPH as of now definitive management nothing was done, but still his urine output is maintaining. So
Without the stones also somebody can put stents in the kidneys?
if yes sir, for papillary necrosis, if one episode is there, we some post transplant for initial post transplant period.
Pyelonephroid is also they place stones?
It is not as such indicated, but practice, some urologists practice.